Good morning, everyone. Welcome to the topical webinar for the month of July. I have with us Rachel Post and Virginia Selleck, who are going to do a presentation on integrating supportive housing and supported employment. This is Dawn Miller with the Healthcare Authority Division of Behavioral Health and Recovery. And if you hear background noise, I will apologize. I'm at a conference out in the lobby manning a vendor table. And actually, it's not the background noise, it's the foreground noise. We're the background noise. I will also mention that, as probably a lot of you know, this webinar is typically scheduled from 8:30 to 10. They've new and improved the GoToWebinar system, and so it shows up as 8:30 to 9:30. Please do continue listening when 9:30 rolls around, and we're hoping to be able to go to 10 as we would normally do, but if for some reason that does not work, I'll apologize in advance. So having said that, I'm going to turn it over to Rachel Post. Thank you for attending.
Good morning, everyone. Thank you so much. We're very excited to be speaking with you today. Virginia Selleck and I have been providing some technical assistance to the state related to the Foundational Community Supports Program and Supported Housing and Supported Employment. Today, as Dawn mentioned, we're going to be talking about how to integrate those two practices. And I would like to go ahead and turn this over to Virginia. I'm going to attempt to advance the slide here. I apologize. Oh, there we go. So Virginia.
Hey, thank you, Rachel. Thank you, Dawn. This is Virginia Selleck. I'm speaking to you from Chicago, where we're in the midst of big-time thunderstorms. And I have all kinds of hopes that they will not interfere with what we're doing this morning. But if I suddenly, leave the thing, it's because I was struck by lightning. Hopefully that won't happen. Anyway, what we're going to do today is go over the shared principles that we have identified between supported housing and supported employment. We want to have a chance to look at some of the operationalizing principles. So principles are great, but you have to figure out how to put them into actual practice. And we think that one of the paths to really doing that integration properly is to have a mutual understanding of how both supported housing and supported employment wrap around or are influenced as social determinants of health. That we also know that some of you folks may have heard some of these things before, and so some of this material may be review for you. Some people are now just getting to doing the work, and so they may be more meaningful than they were when we were just speaking sort of in an overarching way. So we're going to plunge in here and hope that this will be useful to you. We do want to hear from you as time passes by, so as you're doing your work, feel free to use all the options that you have to reach out to Dawn and Lisa and the people that you work with on the supported housing side to talk about any issues that you're having with integration. And so these, so you could advance the slide, Rachel, if you would. So the social determinants of health that we want to kind of focus on here, you see the list there, and it's a long list. However, the thing I will want to point out is that some of them are intervening variables to the others. I'm not sure if all of you are seeing these slides, and so in the case that you're not, I'm just going to briefly read these. Social determinants of health have been, just in general, the field has moved away from thinking about these determinants of health from just things like clean water and lack of pollutants in the air and so forth, to thinking about the social aspects of a person's life that determine their health, is what that means, social determinants of health, and you'll see it abbreviated as SDOH sometimes. Things like social status, your childhood experiences, education and literacy, nutrition, employment, income, physical environment, access to health care, social support network, culture, race, ethnicity, and exposure to racism, and gender and exposure to sexism. All of those things are not totally standalone, obviously. And you think, when you look in the middle of that list, we all know that income definitely has an influence on some of the others. You know, people with more resources can, live in better housing and can have better nutrition and so forth. So it's important to think of these as a cluster of factors that influence a person's overall health. You want to advance, please? We want to now think about, though, now that we know those things, there are specific modifiable things that what we can do with individuals, this is SAMHSA's idea about what the modifiable risk factors are that people experience. And as we go through this list, it's important to think about that these areas that we're going to go through are areas that you, in your work as a supported employment or supported housing person, can directly affect, can assist people in directly affecting their health by addressing these modifiable risk factors. So, for example, smoking, weight, inactivity, people who are working in these times typically aren't able to smoke at work in the way people used to be able to do. So it reduces the amount of time that people smoke if they are in a situation where they can't smoke. Weight and inactivity are both influenced by being up and moving around. Typically, if someone has a job, they have to get off the couch in the morning and go to the job, typically. And so working, for example, influences some of the modifiable risk factors. Lack of access to care is a modifiable factor. That's something that you guys are working on. You're assisting people to get care. Social isolation, vulnerability to violence. Think about how housing, supported housing, can really have an effect on social isolation, vulnerability, and violence. If people are in safe housing, they are more likely to move around the community and be safer. Medication and polypharmacy. The polypharmacy one is another one that's important. Those of you that are working in supported employment will be, but well, both of you, as we'll see in a minute, we go through our things that are similar to both of you, both sets of employees, shall we call you, workers, are that everybody has to be paying attention to the medication that the person served are using and be on the lookout for polypharmacy where it is not known about. And of course, unemployment and poverty definitely affect people's income. If you are poor and unemployed, all those other issues are worse for you. And then, of course, for you guys, and most importantly, the separate silos of care. The whole point of doing this conversation and others that we are doing around the integration of these two practices is in effort to remove some of those silos of care, even though the systems have been built parallel or, you know, with boundaries between them. You guys are sort of the bridge between them. So please advance. The next slide will say to you, are you there, Rachel?
Yeah, it's a little bit, there we go.
There it is, you got it. It's just tardy, that's all right.
Yeah.
I just want folks to be aware of this meta-analysis that was done by Joe Maroney and David Hoff back in 2016. They did a paper for the state of Washington. Some of you may have been exposed to this material in the past, but this is an important thing. It changes the way your brain works around the difference between causation. So that studies going back as far as 1938 determined that employment is the cause of, rather than the result of, increased mental distress, social disconnection, increased substance use, and physical illness. So it's not that you get ill or you get socially disconnected and then you lose your job. You typically, on the whole, of course that happens from time to time. We know that people will have a bad event and then their job suffers. But if you look at all the research, if you thought about it in the way that employment is actually a health intervention, then the way you think about what you're doing changes. You don't wait for people to get better from those things, those increased substance use or their physical illness, and then think about work. You think about work as a treatment to avoid those things. Carry on, Rachel. So these are the principles that we believe, Rachel and I have looked over these things and believe that these are clear principles that the two practices, that is IPS, supported employment, and supported housing, have in common. And we would hope that you will spend a few moments kind of pondering this. So looking at the concept in the middle, for those of you that are not seeing the screen, this is basically a grid that has the principles of IPS on the left, the principles of supported housing on the right, and then the shared concept in the middle. So briefly, the client preferences at the center relates to both situations. So for supported employment, we do careful career profile planning, making sure that you're working with somebody on a job that they will be interested in or a career they're interested in. And in supported housing, similarly, you look at person's personal preferences to find the best setting where they will be happy to live or safe to live. Zero exclusion, and at the very end of our talk today, I'll reflect on what we're hearing, that's a concept that may be harder to kind of wrap your mind around. And so if it is, this is something that in future times we may talk about. But zero exclusion means that on the supported employment side, that people, if they say they want to work, we help them work. It doesn't matter whether they've had many hospitalizations or whether they're using substances or any of the other kinds of perceived barriers. That the main point here is that if people say they want to work, we work with helping them work. It may be that we will help them modify what they're thinking about doing, but essentially we don't say to somebody, well, you got to go get better, or you got to stop using substances, or you got to do anything else before we work on employment. Similarly, supported housing finds housing to fit the person, not trying to sort of shoehorn the person into a housing situation, and that harm reduction is directly related to this notion of zero exclusion, which is to say that we work with people where they are in their course of wellness or not wellness, and think about how to reduce the current harms that they may be experiencing through their housing or lack of housing situation. Acting with a sense of urgency.
If I may,
please.
Virginia, if I may, I'm going to just ask folks if you can see the slides, because I think everybody can. Would somebody please type into the chat box and let us know that you are in fact seeing the slides, so that we can be reassured that makes it a little easier to do the presentation if that's the case. So if someone would go ahead and type in and let us know that you can see the slides, I would appreciate that. Onward, Virginia.
Onward. Anyway, we act with a sense of urgency. We don't wait a long time for somebody to get housing or to get, we think of housing first as the first thing we do in order to help people move into recovery, as opposed to waiting for them to recover and then getting them housing. Same thing with employment. We want to be speedy. This is a key one here, integration with behavioral health. I know that a number of you may be working in agencies where some of your agencies are doing both supported housing and supported employment. Some of your agencies are only doing one or the other and having to integrate both with behavioral health and with each other's work as supported housing and supported employment. But a key concept of each of these practices is to be integrating with the behavioral health personnel if you yourselves are not the primary provider. And benefits planning is key, so that we want to determine the effect of people's income when they start working, what's it going to do to their housing subsidy, their benefits, their entitlements, and the same thing is exactly true with supported housing. Community integration, of course, is a key concept, meaning that we don't isolate people in jobs or in isolated housing situations. And the key thing that is shared along the whole range there is the follow-along support is a key concept. I'm going to turn it back to Rachel, who is going to drill down a little bit more on these principles.
And I will report in looking at the chat that people are seeing the slides just fine. So we're in good shape.
Okay, good. Thanks.
Great. So now, thank you, Virginia. So I'm going to talk just in a little bit more detail about evidence-based permanent supportive housing principles, so that folks, are working from the same understanding of some of the definitions of the principles. So, and some of this will overlap with that prior slide, but basically, we're making sure that we're offering individually tailored and flexible supportive services that are available to folks, ideally 24 hours a day and 7 days a week, and that are not a condition of ongoing tenancy, so that when we enroll somebody into a supportive housing program, that we're offering services that meet their needs and their stated needs, that people are able to access assistance even after hours. So if there's a crisis event or they're needing some assistance in identifying activities on the weekends, that people have the kinds of access to staff who can provide that for them, but that they're not required to accept those services. So the real trick here is making sure that staff are trained in ways to engage people where they want to receive services. Individuals served can accept or refuse treatment or other services, but staff can't refuse to work with individuals who are enrolled in supportive housing. So they must continue to offer support and use flexible engagement strategies. Those of you who have done this work for a while know how important it is to be able to, check in with folks at different times of day or sometimes different days of the week in order to see whether they may be ready if they have previously refused. Sometimes we need to, try using a different case manager with a particular client who may be more likely to accept services from somebody of a different gender or different racial or ethnic makeup or age group in order to help folks engage. The type, location, intensity, and frequency of services adjust to meet the tenant's changing needs. We may have someone who, when we first enroll them, they're really needing a lot of attention and support in the community. Over time, as we're successfully engaging them into services, they may need less services, but it's important that the services are adjusted to meet those folks' needs. And that, again, someone may be stable for, months or a year at a time and have a critical incident or a crisis. And so we need to be able to increase services to meet those needs. Housing is affordable, with tenants paying no more than 30% of their income for rent and utilities. We understand, that there is an affordable housing crisis in Washington State, in actually much of the country, and that sometimes, this attainment of a 30% of income, which is oftentimes SSI for folks who are on SSI, and for some folks that we're serving in our programs, there may be zero income, that the 30% may be an ideal, but that is really what is recommended. And that leases are held by tenants without limits on their length of stay and at a location of their choice. Again, this is an ideal. It's a standard that we aspire to, that we think produces the best outcomes. We also understand, given the housing shortage, that we can't always find rental properties in the exact location or community of choice. But it's something that, a program ideally is not saying to a tenant, you have to live here. This is the only place that, we have to offer you. I think people just need to understand the limitations in terms of the availability of affordable housing units and be able to make decisions for themselves about that. Ongoing collaboration between service providers, property managers, and tenants to preserve tenancy and resolve crisis situations that may arise, and to promote recovery. This is so critically important. Again, those of you who have been doing this for a while, the value of providing how important it is to maintain relationships with your property managers, with on-site housing site managers when problems arise, to intervene and to be able to address those issues in the moment, so that we can make sure that we are, as service providers, continue to be regarded with respect and trust, and to be able to retain relationships with property managers. And it's also important for our participants to know that when something arises, that our supportive housing staff will be there, and just coming to trust that supportive housing case managers and teams are going to be there when crises arise. That in and of itself can help promote recovery and help people just sort of relax and trust that they can attend to other things. So evidence-based supported employment principles, many of you on this call are operating using these principles. You've received training on supported employment from some of the folks here in the state. But just to review again, what those principles are. Rapid job search, so working with participants ideally to help them secure interview for jobs within 30 days of enrollment. So it really is about getting quickly to assisting people in finding jobs in the community, and jobs, as Virginia stated earlier, that they're interested in, something that excites a person. Attention to interest, as I just said, and I think every one of us can identify with this, that we perform better in jobs that interest us than in jobs that really have no meaning for us. And the same is true of the people who are served through supported employment. People want to do what interests them. And so part of working with folks on identifying their interests may be, having conversations about, what did you dream about when you were a kid? What kinds of movies or stories did you gravitate towards? What was it about that interested you, to help people identify for themselves, things that they're excited about? We're really interested in competitive employment, so finding real jobs that anyone, regardless of their history of homelessness or disability, can compete for, and that pay the same wages that, again, someone who's not served through the social service sector or affordable housing system is paid for those jobs. Doing systematic job development, so the supported employment specialists are systematically visiting employers based on their participant workers' interests, and they're learning about the business needs and hiring preferences of employers. And so, I've seen programs where they will, as a team, do a brainstorm of all the employers in the area in different sectors where program participants have expressed interest, and reach out to those employers, ask folks if they can take them to coffee, talk with them about what their emerging practices or needs are within that business, developing relationships with those employers so that they may consider working with our customers. So Virginia spoke earlier about this zero exclusion. So eligibility for supported employment programs is based on clients' desire to work, regardless of their history of illness or substance use. We talked about that earlier. Sometimes employment can be the catalyst to people reducing their substance use or accepting mental health services. It can give folks a reason to not use, a reason to get out of bed in the morning, something to give individuals a sense of purpose, help improve self-esteem. So that's really important. We never know who may or may not be successful on a specific job until we try. And I certainly know that both Virginia and I, and many of you, have seen some pretty remarkable, results with folks who we may have had preconceived notions weren't going to be able to do a job. Service integration, Virginia hit on this earlier. It's so important for supported employment specialists to work in partnership with behavioral health and housing providers to coordinate care, for everyone to be on the same page, and to do that in conjunction with and coordination with the program participant, so that they are really driving the service package and helping in that partnership and collaboration. Benefits counseling, as Virginia talked about, the supported employment specialists and clients review the impact that employment earnings will have on their SSI, SSDI, their SNAP, TANF, and other benefits and entitlements, as well as if somebody has a housing subsidy, what is the impact of that income going to be on their ability to retain a housing subsidy. That helps to really alleviate a lot of anxiety for program participants, as well as for housing staff and behavioral health staff who may not be versed on, what is possible in terms of income and retention of benefits and entitlements. And then long-term individualized support. So participants receive ongoing supports to assist with their successful maintenance of jobs, accommodations, departures, so that somebody can leave a position that isn't a good fit in a sort of responsible manner that isn't burning bridges, as well as really working with folks on career advancements. This may be, your first job, but it doesn't have to be the end all to be all. We can be working on how this is helping you to reach some, longer term career goals and helping participants access training opportunities or, college credits to advance towards something that that they've always dreamed of. Okay, so Virginia, I'm going to turn it back over to you.
All right. We need to think about the work that we're doing as supported employment, supported housing individuals, it's kind of like a job matching or career profile for ourselves. Important to look at the core competencies that it takes to do this work. And I think it'd be unlikely that any particular college course or any other kind of training would really prepare everybody for this. These things are a mix of skills that you learn, or education, I should say. These core competencies, some of them come from education. You do learn things about trauma-informed practices, for example. This is a subject that we hear a lot about maybe in the last 10 years. Before that, it was not something that we heard a lot about. Now there are trainings on it and a lot of information we didn't used to have. So people, all people are learning about this in the behavioral health field. There's another set sort of characteristics that I would say have to do with your personality. Some of these things really are innate to you as individuals and your willingness and ability to do some of this working across the boundaries that we'll mention here in a minute. And also your willingness to be flexible in your work habits and your style. I believe some of you may find that if you are, some of the services, supported housing or supported employment, are being added to organizations that maybe in the past were sort of typical community mental health centers. And, we're working on, therapy and rehabilitation and things like that with people. And then when you add on these evidence-based practices of supported housing and supported employment, sometimes it's difficult to figure out how that's all going to integrate into what you've been taught to do, or things as the way things have always been done, so to speak. So part of this allows you, I'm going to go through these things here, and I would invite you to think about yourself and your feelings of competency or willingness or interest in these particular core competencies. And as the work proceeds, and as we will have another webinar, I think in October, around the concept of this integration, and I know that you have many other training opportunities out there, to think about where you wish that you would get more help. If there's things along this line that you feel to yourself that you're a little at sea, or you don't feel like your agency is supporting you in doing these things, it would be good to reach out to somebody so we can make sure you get this opportunity to feel confident and comfortable in the role. So I already mentioned, the trauma-informed practices, which you think about how that fits for you helping somebody get a job or get housing. If somebody has been traumatized in a certain way, it might be important for them not to work if they're a woman, they may not be comfortable working in a factory with all men. If they have been, the way the housing is laid out, if they have to go into their apartment or their home through a dark passageway and the lighting isn't good, this may be, triggering them. Details like that are things that you will have the opportunity to explore with people, but you can't explore it with people unless you're aware of those underpinnings of trauma-informed practices. Using a strengths orientation and being solution-focused and person-centered is really essential. So that has to do with, and I know we've all heard it, not what's wrong with you, but what's happened to you, or what what can you do? You know, we're hearing a lot about, I don't know if you guys are paying attention to this, but I'm seeing it everywhere now. This is the anniversary of the landing on the moon. Most of you probably were just gleams in your parents' eyes back then, but I was around. I remember going out and looking at the moon. But whenever the space race started, and whenever some of the difficulties were happening when people were in space, and there was some problem with the astronauts, the people on the ground didn't say what's wrong up there. They said what is still working, and that was how they started troubleshooting how to get them safely, get that astronaut stuff to be working safely. So think about that: what's working, and what happened to you, as opposed to what's wrong with you and so forth. So it's a way of shifting your brain. The difficult one and this is the personality stuff, I really think, this ability to navigate other systems and coordinate with a variety of partners. The whole list, there's a string of them, hospitals, clinics, probation, parole, landlords, Social Security. You know who you're talking to every day. There's a string of people. And sometimes it's very tempting to think that my agency and me are the only ones that really care about these people, and the rest of them are just a bunch of miserable bureaucrats. And when you get yourself in that mind frame, it is very difficult to be collaborative and to make good relationships with these people. It is, in my long work in various settings, both state work, private provider work, and etc., I do believe that creating a personal relationship with your partners out there, or I should say a collegial relationship, cultivating a collegial relationship, even if the other people are snarly, you really have to. And it's not about whether you like them or not, it's about what they can do for your client. And so those are things to keep in the back of your mind. Then we get now down to the ability to break tasks into clearly defined steps for clients and sometimes partners. It's also, can you break down tasks for yourself? You're going to be confronted with individuals who have a multiplicity of challenges. You will find people, and you are obviously, people who are not employed, people who are physically ill, people who are homeless, people who have objectionable personal behaviors that seem to be insurmountable barriers to getting well. So your ability to write it all down and pick what you're going to work on and be clear with the individual to break those tasks down and then sequence, figure out what am I doing first, what am I doing second. We used to have a cartoon that was pretty funny of a guy standing there, and it says first pants, then shoes. Think about what has to happen in order for the next thing to happen most easily. And then again, a personality factor, whatever it takes, situational assessment, meaning to resolve the crisis-related events and threats to housing and employability. Whatever it takes is a thing that you have to work with on your team. What does that mean to your team? What will your agency permit you to do, whatever those whatever things are? There will be times when you will have to walk the line between, I'm putting air quotes now around rescue, versus having somebody have a life experience that's learning, having consequences of their actions. We have all heard the phrase, the dignity of risk. We want to make sure that people are not overly protected, but that they are also not overly penalized. So figuring out that balance for each individual that you are working with and how you're going to respond to them. It is really the art of the work. This is the sort of artful part of this, where you're not always going to find this, in a college course. Then the part that everyone loves so well, the ability to keep timely, detailed, and accurate records of your encounters. The case noting, the charting. We know that in Washington, you are so, or maybe you aren't aware of it, but I can tell you, working with many other states, that people are very jealous of your state, that you have the foundational community supports and that you have this Medicaid waiver that permits you to use Medicaid to support these services in a way that there may be one or two other states that are approaching, getting there and doing it, but using Medicaid really requires, the bargain with Medicaid is that what you're doing, meets the rules and regulations, and there's always a need for exquisite documentation to demonstrate that you are doing what's within the scope. But that it's more than that. And if you only think about it in the sense of, I'm doing this because I have to do it or we'll get an audit exception, it becomes more of an onerous task. It is I don't love doing it, but it's hard. But when you think about it also, that there are turnover, staff come and go, people, organizations change. and the person served is really at the mercy of whoever wrote down things the best the last time they were seen. So it is very important that you make sure you can keep track of how things are going, and also this slide mentions that records are critical for coordinating care and documenting efficiency. This is absolutely true. We want to be able to demonstrate that the services that we're providing have resulted in, good outcomes for people. But also, you guys are juggling people's, whether they are or are not on Social Security, who's keeping track of the wages, does it go to the wage and hour people, the details that people, especially if somebody is homeless, they're not carrying around a briefcase with all their personal documents in it. Sometimes you're responsible for hanging on to people's, important materials. Life is very complicated, even if you're not a person that's receiving public benefits. But when you are, it's twice as complicated, and you are often twice as unable to really keep track of those details. So you're sort of a remote access brain for people, and that's a core competency. You will find, if you have not already, if you're working as a team, you're going to find some people, some of your teammates, and this is a thing I would suggest as you work with your teams, some people really feel fine and enjoy the crisis aspects. When somebody's in crisis, they're ready to leap to it, and they're flexible, and they can get along with everybody, and it's great, but maybe they hate to do records. Somebody else might be a person who's very much interested in helping the team be coordinated around paperwork, files, scheduling, and so forth. So, that's why we have more than one person on a team. People have all different skills and abilities. And we're interested in your ideas and your experiences of what kind of core competencies that you found you needed if you didn't know it once you got into this work. And so Dawn will help us collect up that kind of stuff that we can then feed back and allow you to help each other across the state. So now Rachel is going to kind of give you a good example, a case example of how this can be done and has been done successfully.
Great, thank you so much.
While Rachel's transitioning over to that, I'll mention again, if anyone wants to make a comment or they want to add information or ask a question, you can either raise your hand or you can type in the chat box, and then I'll make sure that Rachel and Virginia see that.
And I want to just tell you guys that if people typed in the chat box already, I don't see it. So at my end, I do not see any chats. So if anybody says anything that I should know about, somebody else.
You bet. There are none so far. So, just definitely, if anybody wants to ask a question or that kind of thing, you have a couple of different options in order to do that.
Thanks.
All right. Well, thank you so much, Virginia. I love working with you and presenting with you because I feel like I always learn so much new and new ways to also just represent things that are so powerful. So thank you. I wanted to talk about an example of an organization, and I realized, I think at the start of this, we talked about the fact that some of you are working with organizations that only, and I don't want to say only as if to suggest that it's not significant. I meant that are providing support employment services specifically, and some of you on this call may be working in an organization where you're a supportive housing provider, so you're not providing both elements of care. But I'm going to talk to you about an example of an organization in Portland where I worked prior to coming to the Technical Assistance Collaborative that was operating the supportive housing, behavioral health services, as well as then incorporated supported employment. So this is a case study of that. So this is a Portland-based organization whose mission is to end homelessness, and they've been providing services since 1979, and I should say Portland, Oregon. And in 2007, the COO authorized the senior director to begin the adoption of the supported employment or individual placement support model, also known as IPS, and to start turning the existing workforce development program into adoption of the support employment program. And by 2011, the program had the highest fidelity score in the state. So at the time, the state the state of Oregon had funded 18 sites in 2011 to operate supported employment programming. And they also had their own state fidelity review division that would go out and conduct fidelity reviews to determine how close to the model, supported employment model programs were. And this site scored 116, I think, out of 120. And in 2014, this site was recognized as one of 11 exemplary programs by the United States Interagency Council on Homelessness, HUD, and the Department of Labor at a national summit on integration of supported employment and supported housing. And by 2017, they had the highest percentage employed, so 70% out of, at that point, there were 34 sites in the state of Oregon. And by that point, this site in Portland had been able to increase its capacity to employ 22 supported employment specialists who worked with 790 individuals who were employed in that calendar year. So you can kind of see the timeline in terms of from the point at which the program was adopted to 2017. And I'm going to talk now, if I can get my slides to advance, about some of the challenges to the adoption. So the supported employment adoption was met initially with some resistance within the organization and the community, and by some of the organization's highly respected leaders. There were concerns expressed by the agency's medical director, psychiatric director, mental health director, the director over the substance use disorder treatment, and even the employment center director, people who thought our clients are too sick to work. Those clients who are enrolled in outpatient alcohol and drug treatment, they can't be thinking about employment. They really need to focus on treatment, and we don't want you talking with them about employment. That's going to interfere with their recovery. Folks who thought employers are not going to hire these clients because they had histories of corrections involvement. They had, some of them active substance use disorders, co-occurring mental health disorders. And people just simply thought that we weren't going to be able to attract employers to hire the individuals we were serving. And then discussions of implementing the supported employment IPS model were met with, sideways stares of disbelief from leadership and frontline staff alike. But there was full-on commitment from the COO and the CEO to adopt this and really kind of force this shift in the organization's orientation. So the steps that we engaged in order to really move through a lot of that concern and resistance and doubt were the following. So, we, again, because we had the support of the CEO and the COO, we were able to make presentations to the board of directors and leadership using published studies about the IPS model so that we could document that, these were the characteristics of populations in other parts of the country who were served effectively using supported employment. And I think it was hard for people to sort of refute, published research about what has worked. We made presentations to program directors and managers, instituted an adoption timeline that the management team was accountable to. So it wasn't a question of, well, do you think we should do this? It was more of, we're doing this and this is the timeline and this is what's going to be involved. So rolling out the programming that was targeted to supported housing building. So one particular site, this particular organization at the time operated about 1,700 units of housing in 23 buildings around the city of Portland. And so we identified one specific building where we were going to pilot bringing supported housing into that supported employment into that supported housing program. And then over time, as we were able to successfully, bring online supported employment with that one building, which had about 100 tenants who were in recovery from substance use disorders, about 70% with felony convictions, we were able to then sort of start spreading the model to other buildings. And with that rollout, we provided rigorous supported employment training to both the supported employment staff who, all of these folks, as many of you were new to this concept of supported employment, as well as to the supported housing staff. And we did that with them together to sort of set the stage and tone for this is something that we're going to be relying upon you all to work on together in coordination and collaboration. We began using the fidelity scale that's published. SAMHSA, for those of you who haven't seen it, SAMHSA and Dartmouth have, you can find links to the fidelity scale. We used that to monitor the implementation immediately and to convey to the staff the intention that we were going to adhere to the full model. This was something that we shared with frontline staff as well as management. And we participated in independent fidelity reviews annually that were administered by the Oregon Supported Employment Center for Excellence. So this was the third party funded through the state of Oregon to ensure that sites that were receiving funds for supported employment were actually fully implementing them to the faithfulness of the model that had been documented to be effective. And then we promoted the success stories of the supported employment program through social media and pursued partnerships with the Department of Vocational Rehabilitation, the Department of Human Services for families who were on TANF, and with the Workforce Opportunity Act funded systems. This took time, it took persistence, was initially met with a lot of, I think, doubt, skepticism, but over time we were successful in developing those partnerships. So now I'm going to talk more about some of the micro level culture shifts. Unless there are any questions, Dawn, I'm sort of relying on you to.
I apologize for there's evidently someone said something very good because there's loud applause in the background. I did see that Vicki had her hand raised for quite some time, Vicki Gillig. I don't know, Vicki, if you want to type in the chat box, or I can try and unmute you to ask the question you wanted to ask. And in fact, you're unmuted now.
Oh, hi, Dawn. My question was just, I'm such an advocate for benefits planning, and when she was going over the services that are provided, we're just finding a lot of barrier to wanting to go to work because of fear of losing benefits. Our concern is what quality and capacity is out in the community to provide that service.
So one of the things that I would mention is we've had some online or some in-person trainings done by Washington Initiative for Supported Employment on benefits planning. We have a series of webinars that they are going to be doing that will be coming up because, at least in my mind, and I'm not sure about others, but I think it's important for line staff to have at least a basic understanding of benefits planning. Over and above that, community-minded enterprises carries a contract in order to do benefits planning, and I would encourage using them in the more convoluted cases and having staff trained in the basics. And then if there's question other than that, I know there are providers that have benefits planners that are willing to contract with other agencies in order to do benefits planning for individuals. So there are some options out there. Some of them may be harder to access than others. If folks have questions after the fact, they could get a hold of me or Lisa Bennett Perry. Lisa's the one that's been monitoring the contract for setting up the webinars for benefits planning through the WISE Washington Initiative for Supported Employment. I keep saying that, spelling out what the acronym is, because I'm at a conference for WISE, which is Wraparound Intensive Services, and so there's more than one WISE in the state of Washington.
Right, it's confusing. It does help. We've got a lot of Medicaid waivers in our aging long-term support agency, and so we've been trying to find certified benefits planners and giving them additional information about our COPEs and community first choice waivers, that type of thing. So we're trying to build as well. So it's really helped having those WISE webinars and workshops. And so kudos to you for getting that off the ground, because it is a very, very important this success of this. So thank you.
Thank you.
All right, shall I continue? This is Rachel.
Yes, please.
Okay, great, thank you. And thank you for the question, Vicki. That it's so important that that communities have the availability of training to be able to address those concerns related to benefits. I wanted to talk about some of the sort of more micro level or smaller, frontline staff kinds of efforts that we went through in order to help shift the culture at this particular program. So, it was important at the time that we were adopting the support employment model to make some changes to the hiring practices or the types of providers that we were recruiting into the supported employment program. So it was really important to make sure that our interviews helped screen in people who believed in the possibility of recovery and who believed that people could work, and to screen out those folks who, I talked about earlier, some of the initial doubts that we were met with at the leadership level. So it was really important to make sure that as we were hiring frontline supported employment specialists and a manager, that we hired people who believed that people could work. Team and individual supervision celebrated again, because, we didn't have the benefit of hiring a completely new team. We had some staff who had been in the employment program that had existed for, say, 10 years prior, who we were sort of shifting their job responsibilities and roles, but they were folks who were skeptical. And so it was important in supervision to really celebrate successes and, again, people who believed that the population we were serving could be successful, and then help those who weren't sure of it, coaching them along to perhaps find other jobs within the organization that were going to be a better fit for them. The program successes were disseminated to those targeted for expansion. So to the outpatient treatment counselors, to the assertive community treatment team. There was a day psychosocial rehab center. And so making sure that we were really sharing the stories of people who were successfully placed into jobs in the community, so that we could, again, start to sort of shift or flip the script within the organization about what was possible for folks. And then we also had to operationalize what integrated and coordinated services looked like. So we really needed to be very clear about what we meant by integration. And so we started to set expectations that supported housing and supported employment staff would meet together with program participants at the very point that they came into the housing to establish a service plan that had measurable actions and outcomes that were specific to both their housing stability as well as to their success in securing employment. Supported housing and supported employment providers also met with the program participant as a team every 2 weeks to update the service plan so everybody could be on the same page. They attended joint team meetings 1 time per month to brainstorm the obstacles to successful attainment of participants' goals. It was really helpful to have all of the support employment specialists and all of those housing case managers together in a room to go through caseloads and talk about creative ways to help people be successful. It was kind of infectious because you would have someone sharing a story of a unique and innovative engagement strategy, and other folks would just have this sort of aha moment, like, oh my gosh, I never thought of that. So that was extremely helpful, as well as then having the supported housing and support employment staff meet with mental health and or the outpatient alcohol and drug treatment providers monthly with participants to review their service plan and to assure everyone was working together. And then, you know, in order to be able to do this, we had participants when they were willing to sign releases of information so that would allow for coordination of integrated services. And then we also, just to further ensure that integration was happening, we had in this agency a quality management and IT department that was engaged in actually reviewing the programmatic outcomes and measuring the degree of care coordination so that improvements could be made. It was really helpful actually having the statewide fidelity review, because that helped sort of hammer home to those other departments that this was something we were going to be evaluated on, and we needed to know in advance of those yearly reviews how we were performing. So it really brought all hands on deck to look at what was happening. And using, you know, because this agency was a federally qualified health clinic, they had an electronic health record. And that also, in those records, the clinicians would be able to see that somebody was enrolled in supported housing and supported employment, so that there could be even better coordination with the services. So while I understand and I really appreciate that this was one agency that was able to make this shift to adopt supported employment and then to help institute coordination and integration, I have seen in other communities, as I suspect, you know, some of you may be doing as well, and Virginia has probably seen, and Lisa and Dawn, where there are memorandums of understanding across agencies, where one agency is the behavioral health supported housing provider and another agency is a supported employment provider, where you can institute many of these kinds of agreements in order to accomplish much of what was illustrated in this case study. So with that, I'm going to pass this back to Virginia to talk about some of the specific areas that Washington State is challenged by, and that we've heard from some of you folks on the ground, as well as from Lisa and Dawn. So Virginia, I'll pass it to you.
Okay, and I would like to say that we haven't heard as much as we would like to from the field, and so in terms of what is going well and what is going less well, and it would be really helpful to us as your helpers to get a good fix on exactly how things, you know, are working well or not. And I don't know, and I'm hoping also we're going to find out in 1 minute if this webinar is going to pull the plug on us or if we're still going to get to be here. And if we're still going to get to be here, I hope that those of you that are out there will be putting stuff in the chat box or raising your hand or so forth, because we'll have almost a full half hour for, or at least 20 minutes for, you know, back and forth conversation, which is what we always hope to have with you. I want you to actually, though, reflect back on some of this information that was in Rachel's most recent slide. where there were specific time frame things that people were doing. It said things like meeting, that both providers were meeting with the person at intake. That's a specific time. That the program, that the teams were going to meet every 2 weeks. That there were things that happened once a month. I saw a really interesting presentation on leadership at the National Council meeting. It was a person, she did a keynote, and I really am sorry, I can't remember her name, but she was an ex-military person. And her point was that when you're trying to make change and when you're trying to bring any kind of a new practice to bear, you have to think that soon is not a time. If you say I'm going to do it soon, well, that's not a time. You need specifics. There was another thing she said too that was along those lines. The point being that it'll be easier to figure out what your real challenges are once you get an established structure for how you're going to move through these things. So I would suggest that you take a look at Rachel's micro level slide thing in terms of how are you really operating on a day-to-day basis? Is it really clear about who's meeting with who and when, and how to get that done? The other thing I would comment on in terms of organizational change is that just as we work with the individuals we serve on meeting that stages of change, that you want to match your intervention to the person's stage of change, which is a universal principle when you're trying to do work with people. The same thing is true with organizations. The only difference is that there's not an option for people to change, and that's, I think, where Rachel was gently saying that they were coaching out skeptics. That's very important. But part of what happens is you match your intervention to the stage of change, and often people who are resistant need a lot of education. And once they get the education and see the value of what's going on, then they go along. But I've also had organizations, the last one where I was a clinical director a few years ago in St. Louis, where people just say, I don't want to do it this way. I like the way it was before and I'm not changing. And those people, you got to, be specific and clear that the organization is in fact changing whether they want to or not. So that's what's a little different than when working with a person served who, of course, we are guided by the person's wishes, as opposed to whenever you're an employer, sometimes you have to be a little more firm. But what we've heard about here so far from you folks in Washington, and again, is that that there is need to make sure, and I'm not sure how many of you that are out there on this call are on the supported housing side or the supported employment side, if you want to call it that way, what your area of focus is. So this could be going both ways. Is employment on the minds of supported housing providers? It may be that it isn't always, and that's an area of growth where we need to make sure that supported housing providers are aware of both of what the options are, how would they help someone get employed. And I appreciated Vicky's question a minute ago about benefits planning, which it's not only an impediment sometimes to the individual served who's concerned about going to work and afraid they're going to lose their benefits. It's sometimes also, the supported housing person may be concerned because of how subsidies operate and things like that. Rachel mentioned that, a little bit before. So we need to figure out what we have to do to accomplish the shift in attitude on the part of supported housing providers. Similarly, supported employment people need to be mindful of how what they're doing influences where people live. So when you're working collaboratively, one of the things I would invite you to think about, and maybe we can have conversations sometime about it, is what do you do first? If you've got a person who's both unemployed and not well housed, do you find them housing first and then worry about a job? Do you find the job first and then try to figure out how to wrap the housing in? These are probably case-by-case decisions, but it is, again, this notion of having a structure and figuring out how you're going to sequence what you're doing with a person that will bring you into direct face-to-face work with your corollary, if you're, the between the housing and the employment. The other issue that we heard it may be coming up a bit is whether or not staff, both sides, housing and employment, understand what zero exclusion means. In terms of employment, research reveals that the desire to work, is often a much more powerful factor than people's personal history. And as Rachel indicated, we're just really bad predictors. We think that we can look at somebody's, life story and decide whether they will or will not be a successful worker. but experience has taught much